Well, hi, everybody. My name is Garrett Schmidt, and I am the managing editor and CEO of VBC Exhibit Hall. And I would like to welcome you to today's live webinar hosted by Roji Health Intelligence. And it is called MIPS Value Pathways, MVPs, How to Succeed in Post-Traditional MIPS. And this is kind of a part two to a webinar we did a couple weeks ago called the MIPS Value Pathways, MVPs, how to succeed in post-traditional MIPS. And if you hadn't heard that one, I'll send a link out when we're done to everybody so you can check that one out. But you won't miss anything by starting with part two. And actually, we've got a lot of great stuff to cover today. A few items of note before we get started. This is a traditional webinar format, so we can't see you, we can't hear you, and you don't need to worry about muting your mic or anything, but we do want to hear from you. And so we're going to have a time for Q&A towards the end of the session today. And so if you have a question at any time, go ahead and ask it using your control module. There's a little area for questions, which is different than the chat. So if you drop your question in there, we're going to get to it. If we're not able to, for some reason, if we run out of time, someone will reach out to you through email afterwards to answer your question and make sure that that you have an answer there. So even if we're wrapping up at the last second, go ahead and ask your question. And finally, today's session is being recorded, as we do with all of our sessions. So I will be sending out afterwards, you will receive an email maybe an hour or two after we're done, and there will be a link to where you can watch the recording or share it, and we hope that you do, and also where you can download the slides and some more information about how you can get in touch with our speakers and with Roji. So without further ado, I'm going to pass it over to Mr. Dave Halpert, and he is Chief of Client Team with Roji Health Intelligence, and he will be your guide today. So welcome, Dave.
Thank you, Garrett, and thank you all for signing in today. Good morning or possibly afternoon, depending on where you're calling from. Today we're going to talk about MIPS value pathways and how to succeed in a post-traditional MIPS. And so this presentation is for health systems, medical organizations, physician practices. If you're interested in measuring and improving outcomes, providing and demonstrating excellent care for all of your patients, avoiding financial penalties and potentially, hopefully, earning incentives, and finally, just learning more about value-based care in general, this is the presentation for you. Tell you a little about what we're doing today. First of all, we will be showing silly pictures throughout to keep everybody on their toes. I can't help it. But today's track, we're going to be talking about an overview of MIPS components in general, how they're scored, where they came from. Then we're going to move on to the evolution of MIPS itself within the value-based care landscape, where it started in 2017 and where we've gotten to today. Then we're going to move on to what is a MIPS value pathway or an MVP and the challenges associated with those MVPs, both the challenges that you will face immediately, but also in the future, and how to finally overcome those challenges as you take your path to MVP success. All right, so before we proceed, I'd like to do a quick audience poll here. Which of these best describes your MIPS value pathways strategy? So if we could bring up those responses here. I'll stick with traditional MIPS for as long as I can, but I know MVPs are coming. I want to get an early start so that I'm ahead of the curve. I'm not certain that some or all of our providers could benefit from the alternate payment model that we're in right now and are wanting to learn more about the possible MVP route. And finally, I have no idea what an MVP is, but this has been put on my desk as something that is required of my position, and please send some help. Give y'all a couple of minutes to fill that in.
All right, we've got the poll up, so if you haven't voted yet, go ahead and do so, and we'll take it down in a few more seconds. So it looks like most of the responses are in. Okay, let's go ahead and close it down, and then I will bring up the results for everyone to see here. Here we go. Dave, are you able to see the results?
Let's see here.
I can read it out to you if you can't.
Yes, if you could, that would be helpful. Thank you.
Sure. Okay, so it looks like we have 5% with the I will stick with traditional MIPS, 57% with I want to get an early start, so I'm ahead of the curve. It's good numbers. 24%, I'm not certain. Some or all of our providers can benefit. And 14%, which is I have no idea what MVPs are. So it looks like we're all across the board there.
All right. Well, that's actually, I'm actually really pleased to hear that, because starting early to get ahead of the curve as we get through to the presentation, we'll see that that is the biggest thing that you can do, is to start early. So that's fantastic that a lot of you already have that in mind. All right. Little about us. Roji Health Intelligence, we provide value-based care technology and services, and our goal is to improve outcomes, cost performance, and to facilitate our clients to provide equitable health care to all of their population. This is not something that we're doing for one payer versus another. This is for the population at large. And our tools are meant to identify patients with persistently poor or high-risk outcomes and target specific health interventions that will help them to improve on their health journey as they move forward. We want to help people before they are in dire straits. And what we do to do that is to provide our clients with the ability to engage physicians and other clinicians on meaningful clinical improvement for patients. So not just a change in a certain number, we're actually trying to benefit overall health for our clients and their populations. So let's start from the basics. What is MIPS? MIPS is the Merit-Based Incentive Payment System. It's a program that was designed by CMS to measure and reward providers who provide high quality care and can do so without excessive spending. It came from in the pre-MIPS days, before the Medicare access and CHIP reauthorization. We'll see that theme again, the abbreviation within the abbreviation, CHIP being Children's Health Insurance Plans. The MACRA Act, or excuse me, the MACRA replaced the sustainable growth rate formula. And so every year Congress would pass what they called a doc fix bill to postpone that cut that would come up with that sustainable growth rate formula. And by 2015, it got to the point where it was going to be just something that was not possible. No one is going to accept a 25% cut. It's not feasible. And so MACRA was passed, and in the birth of MACRA was the MIPS program. It was one of two components of an overall quality payment program. There's MIPS and there's alternate payment models. MIPS combines several legacy programs into one comprehensive program. That was part of the issue with some of the previous programs, PQRS, meaningful use, etc. It was too much, it was too complicated, and so MIPS is designed to roll everything up. The most important part of MIPS is that it is budget neutral, meaning that whatever people earn in incentives, that must come from penalties. So the more people that participate and do poorly, that is going to make incentive payments greater for people who do well. So the goals of MIPS: first and foremost, lower Medicare costs by improving beneficiary health. MIPS is for all patients, but the payment structure is set up for Medicare only, and the goal is to improve costs by keeping Medicare patients, let's say, out of the hospitals, the emergency departments, experiencing poor outcomes in general. It's also designed to facilitate and improve interoperability in healthcare data. One EHR needs to be able to talk to the other. Patients need to be able to download their own health records for when they visit new providers, things like that. Identify and address healthcare disparities tied to health equity. One of the things that CMS has realized is that there are a lot of health disparities that are related to things like social determinants of health, food insecurity, housing insecurity, transportation, etc. And so MIPS is in part The goal is to improve health for all patients. And then finally, to engage and empower patients in their own healthcare decision making. So the origins of the 4 MIPS components. There are 4 MIPS components. They are cost, quality, promoting interoperability, and improvement activities. Cost comes from what was referred to as the value-based payment modifier. And it was a measure of whether or not your patients were spending more money than than patients from your peers. And it was CMS would look at their claims to determine, let's say, are your patients hospitalized more? What is the overall rate of hospitalization? And finally, what is the total per capita cost or the total cost per average clinical episode for your patients? And that was the payment adjustment. There was a quality component, and that came from what was called the Physician Quality Reporting System. And for that, it was the Physician Quality Reporting Initiative. Promoting interoperability is the third component, and that comes from meaningful use. It's the measure of how well clinicians' practices are meaningfully using their electronic health records. And then finally, there are improvement activities, and that is new for MIPS, and these are programs that you are engaged in that are intended to improve the outcome of your population with a specific target in mind. It may be something related to advanced care planning, it may be tobacco cessation, and it could be something related to your EHR and patient access to care. Your MIPS score is the sum of the combined weighted components. So each of these components, it is not 25, 25, 25, 25. Each one has a specific weight. So what is most important to take away from this pie chart is that cost and quality are both weighted at 30%, and that is by a legislative statute that cannot be changed. And that takes up a full 3/5 of the MIPS score are those cost and quality components. The next largest one is promoting interoperability, 25%, and then the improvement activities make up that final 15%. So based on what you score in each of those components, they're weighted, and then a final MIPS score out of 100 is what you receive. Now, based on that score that you receive, there will be what CMS refers to as payment adjustments, which means either a penalty or an incentive. The way these work is that there is a specific in each year performance threshold. So in the 2023 performance year, where we are now, that performance threshold is 75. So anything lower than 75 is going to mean that you are on the hook for some sort of penalty. Anything greater than 75 means that you are going to earn an incentive. And it is a sliding scale. So someone, let's say, who scores a 74 will have a penalty that is significantly smaller than someone who scores 0 points. That 0 point score is the maximum penalty, and that is a 9% penalty on Part B fee for service claims. And the maximum is a 9 times an adjustment factor to keep things neutral. Before I talk about the budget neutrality a bit more, I want to mention one thing here. You'll note that the performance threshold is for 2023 performance, but the financial payment adjustments do not take effect until 2025. The reason for that is that at the end of, once 2023 finishes, the submission window, which third-party intermediaries submit data to CMS, it's the first quarter, so January 1st through March 31st of 2024. So those are all of that information is submitted during that window. And then once that window closes, CMS then reviews its claims to score some additional quality metrics and its cost metrics. So by the time that is all concluded, we're already well into summer. And so those cannot take effect until that next year, because there also needs to be a process for reviewing any issues that may be that may have occurred in CMS's calculations as well. So moving along, the adjustment factor, as I said, MIPS is budget neutral. And so those penalties, they fund the incentive payments. And so that adjustment factor distributes penalties to keep funds level. So that's what we're looking at here is we've got to keep a balance, and we've got the penalties on the right, the incentives on the left. The incentives are smaller, but that adjustment factor means that is a way to keep things neutral. So if somebody is, if there are a lot of people that are penalized 9%, there are people who may then recoup up to 12%, 13% in incentives. We have not seen that yet, and here is why. There's been a lot of effort so far for MIPS, but not much in terms of a reward. So people who have successfully participated, they were hoping for those numbers that we just discussed on the previous slide, but that hasn't happened. There are a few reasons for that. The first is that the requirements for participating in MIPS, particularly in the early years, were very easy. You could submit even a single response to a single measure in that first year to avoid penalties. And rollout was slow in general when we're looking at whether or not there were, in terms of your requirements for participation. It was a slow ramp up. And then in 2020, obviously, we had the pandemic. And for several years, providers could take an extreme and uncontrollable circumstance hardship exemption and be excused from the program altogether. So if they're excused from the program altogether, that means fewer people who might potentially fail, and fewer dollars that will go towards the people who earn incentives. So big incentives not coming, and then also the complexity of the program in general has created some uncertainty. So on the quality side of things, there are roughly 200 quality measures. They're updated every year. It is hard to maintain a workflow in the office to report the same measure year over year. Little cost feedback has been provided, so that's one of the things that had led to high levels of passing grades, was that cost had been waived or reweighted, and so very little feedback has come back, and so people don't know how they're going to do. So with the change in quality measures, the change in quality performance benchmarking, not a lot of cost feedback, it's really difficult to predict year over year success. You may have a fantastic score one year, but in the next year, even if you are doing you're showing the same performance on the same measures, your score might look substantially different. So where does that leave us? We've got to position MIPS in the value-based care world for it to succeed. The first thing that CMS has done is started aligning MIPS with alternate payment models. So the alternate payment model performance pathway, or APP, another abbreviation within an abbreviation, uses MIPS measures. The A1C poor control, controlling high blood pressure for patients with hypertension, and the screening for depression and follow-up measure, 1, 236, and 134 respectively. Those all come from MIPS. Also, new quality measures dovetail with CMS APM. So there are a couple of measures that have come out related to kidney care for MIPS in 2023, and that dovetails very well with CMS's kidney care models, including the ESRD treatment choices model, the kidney care choices model. They're meant to sort of align people's quality performance into a specific track. There's also an increased emphasis on cost. It contributes more to the MIPS score than it used to. As I mentioned, in that first year, 2017, it didn't contribute anything. And now it is up to 30%. There are additional cost measures that there were before too. They're much more specific, so that providers and practices are scored more specifically in terms of the kind of care they delivered. So rather than two cost measures, one based on the total cost of care for a patient and the other based on a sort of a composite cost of care per episode measure. There are specific procedural episodic cost measures, and now there are specific cost measures as well that are tied to chronic conditions and other primary care type of services. And then finally, the most important thing is that CMS has developed a streamlined participation path to participate in MIPS. So the big concern is that it's too complicated, it's too complex. What we need is a whole new ball game. We need to be looking at something brand new, and that something brand new is MIPS Value Pathways. It's a MIPS 2.0. So instead of being able to choose a set of 6 out of possibly 200 quality measures, MIPS Value Pathways are comprised of specialties and or a clinical set of quality measures, improvement activities, and cost measures. They are designed to focus on one clinical type of area, whether it is a chronic condition, whether it's a type of procedure. It's meant to focus on one specific piece. It's intended to break down the barriers between MIPS components. In years up till now, it is not uncommon to see different people in charge of different components of MIPS. There are the IT folks who are taking care of the promoting interoperability piece, quality people who are looking at the measures, patient navigators doing the improvement activities, and rarely shall they meet. And so this is intended to facilitate comparison by steering clinicians into more standardized profiles and breaking down those barriers. In other words, if you're going to be demonstrating quality on lower extremity joint repair, you should be compared to clinicians who are also trying to demonstrate quality on lower extremity joint repair, rather than a kind of vague comparison in certain measures, but not others. What MVPs will also do is they'll separate multi-specialty groups into component parts for scoring. And so that is something that has been continuously detracted from MIPS. MIPS has its detractors, and one of the primary reasons is that multi-specialty groups are able to select for the entire group a set of measures that may not apply to all providers, make it very easy to hide certain areas of deficiencies or poor performance. And MVPs are going to get people out of that. And it is intended to, MVPs are intended to replace what we think of as traditional MIPS very soon, possibly as soon as 2025. Anyone who watched the House Ways and Means Committee a few weeks ago saw that there were plenty of commentators who had plenty of displeasure to express about traditional MIPS. And so the proposed rule for 2024 should be coming out any day, and it will be interesting to see what more is defined there. So let's talk about the scoring basics for MIPS value pathways. They're essentially the same in that they are scored in the same 4 categories: the quality, cost, promoting interoperability, and improvement activities. There is a foundational layer that is included in MVPs, but those are, but it's included in those 4 categories. You need to report on 4 quality measures. That's fewer than 6 that are required for traditional MIPS, but that's because each MVP is limited to the number of quality, a certain number of quality measures associated with that particular MIPS value pathway. There's also a CMS calculated population health measure, a foundational layer, and that's either all-cause readmissions or admissions for patients with certain chronic conditions, and you're able to choose which one you would like for your MVP, but that's calculated by Medicare looking at its claims. That's not something that you report. There are improvement activities, just the same as in traditional MIPS, but you don't have to do as many of them. The activity points are doubled because they are specific to your MVP of choice. The promoting interoperability measures are unchanged, and that's part of the foundational layer. And then the cost measures are limited to your specific MVP. And in our next couple of slides, I will show you the MVP library. And I'll just read these to you. Adopting best practices in promoting patient safety within emergency medicine, advancing cancer care. And again, as I'm reading these, you'll see how a lot of them dovetail with other CMS programs. Advancing cancer care, obviously related to the enhancing oncology model, advancing care for heart disease, on the same track as Million Hearts, advancing rheumatology patient care, coordinating stroke care to promote prevention and cultivate positive outcomes, improving lower extremity joint repair, which is right along with the bundled payments for care improvement, or BIPSI, optimal care for kidney health. Again, the kidney care models that CMS has in the alternate payment model library. Optimal care for patients with episodic neurologic conditions, optimizing chronic disease management, patient safety and support of experiences with anesthesia, a general promoting wellness, and then finally supportive care for neurodegenerative conditions here. And so for each of these, they are specific, a certain set of quality measures that you may choose from that go with each of these, but they're not something where you're going to be able to pick and choose other measures. MVPs also introduced the concept of subgroup reporting. So traditional MIPS reporting is at that individual or the group level. And group means tax identification number. It does not mean site. It does not mean department. And so multi-specialty groups reporting does not necessarily encompass all of their providers. It's very easy to, let's say, if you needed to report an outcome measure, but your the people who are doing surgeries have a higher number of complications or surgical site infections or reoperations, and you like how your primary care group does in terms of the blood pressure and A1C, you could report blood pressure or A1C instead, and it's very easy to mask deficiencies elsewhere. MVPs are introducing subgroup reporting, and that is the reporting at the specialty level. So for that multi-specialty group I mentioned in my last example, they would have to report on multiple MVPs to cover all of the providers. So it's a lot more reporting, but it is intended to be a lot more meaningful in terms of comparing one set of providers to another. Subgroup reporting is not mandatory yet. 2025 is looking to be the year that becomes mandatory. And so before then, you need to ensure that you've got a path to MVP success. And trying to look forward here. So like more than half of you said, want to be early adopters, which is fantastic. In your early adoption, it is important to read all of the fine print. You do not want to get on an attack that is going to actually hurt you down the road. The next thing that you need to do is to get the expertise and infrastructure you'll need to measure and improve. It's complicated. It is less complicated, but obviously data aggregation, quality measurement, etc. These are not things that are easy. Align your goals to maximize the efficiency of your limited resources. Staffing is obviously an issue for everybody, and even before a lot of the shortages that we have been seeing post-COVID, it just makes good sense to maximize efficiency rather than sending everyone on their own way and hoping that things meet where they're supposed to. And then finally, once you do succeed, you need to continue to improve by leveraging that success. And I'll talk more about that as we go forward. So MVPs are still optional. Why bother to adopt early? Well, there are a few reasons for that, and some of you, I'm sure, have thought about these. The first is that in other CMS programs, ACOs in particular, experience in programs have directly correlated to success. The people who are in it longer, they get more experiences, they work out some of the bugs that are in those initial processes, and they are able to perform better than people who are just starting and learning the ropes. Traditional MIPS is going to be retired. It is as close to a certainty as you could make it, and so you do not want to be caught in a traditional MIPS strategy in a post-traditional MIPS world. So those who start early are going to be better positioned because scoring rules right now are very favorable. If you were to say submit, you didn't want to necessarily go all in on an MVP this early in the game, that's all right. You can concurrently submit MVPs and traditional MIPS, and whichever one earns the higher score for you, that's the one that CMS will give you. In other words, if you try an MVP and you do terribly and your traditional MIPS score is better, you've learned lessons, but you haven't actually needed to take any sort of a financial hit. They're also easier to administer. There are fewer measures to track, particularly in single specialty groups. There are fewer data entry points to standardize amongst your providers. So what I mean by that last point is anyone who's been in the game for a bit knows that yes, you have the same EHR, but each user is different. Different things are input in different places, and sometimes that can catch you off guard when you're trying to demonstrate quality measure performance. Some of the information you expect to see isn't there. It's in the record, sure, but it's not in your results. And so this makes MVPs make it easier because it's easier to standardize workflows for collecting the information that's needed. So let's look at some of that fine print. Don't rely on being able to report just on the electronic clinical quality measures. So with each of the MVPs, there are going to be electronic clinical quality measures. There may be some measures that you can report via a qualified clinical data registry, and then there are going to be regular clinical quality measures, just formerly known as the MIPS measures. First of all, there are not enough ECQMs to cover the 4 measures that you'll need in all the MVPs. So you're going to likely need at least one clinical quality measure and possibly more. The second thing you need to think about is that each of these measures are benchmarked by CMS, and the points that you earn on each measure is based on CMS benchmarking framework. So you can earn from 1 to 10 points on a measure based on your performance. They have ranges for each one. So think school, 90 to 100 for a measure, maybe an A, 80 to 89, maybe a B, except it's much more specific than that. And sometimes they can be, those benchmarks can be extremely tight. And also, just because a measure isn't an MVP does not mean that it can earn 10 points. It may be topped out, meaning it can earn a maximum of 7 points, or it may be such where the benchmark is, or that the benchmark is so high that even a single failed instance may be enough to send you cascading down. The qualified clinical data registry measures do provide options, but remember, these measures must also be benchmarked, and so someone must fail for CMS to approve the measure. So just because it is a QCDR measure and it sounds good does not mean that you are going to necessarily be on one side versus the other. And then finally, remember that foundational layer. Those hospital, the all-cause readmissions, the admissions for patients with certain chronic conditions, these are things that need to always be in the back of your mind. So as you're talking about where do we get this expertise to succeed, it comes from experience. It takes an ONC certified clinical data registry with experience reporting electronic clinical quality measures and clinical quality measures to CMS as a qualified third-party intermediary. 2008 was the first year that was allowed. CMS did not allow people to submit quality data on behalf of providers until 2008. The initial process was in 2007, and just like I've mentioned previously, experience being directly correlated to success, that applies here as well. You need experience with someone who's able to take your data and create actionable analytics on cost and quality. Anybody can provide a list of patients who have high blood pressure or a high A1C. There is more to it than that. Not the least of which is matching and attributing patients to specific providers for targeted interventions. And that's even before we get into the discussion of matching patients. Let's say if you convert EHRs mid-year, how are you going to be able to create a 12-month full year's worth, ensuring that each patient is carried over, not duplicated. It takes a great deal of data aggregation experience to do that. Someone with experience recommending and implementing strategies to improve outcomes, and finally, someone who knows the difference between identifying a gap in data and a gap in care. Different strategies for addressing each of those. The next piece is that you have to coordinate your MVP components. I'm hoping you can see this two-headed turtle because, first of all, it's interesting, and second of all, it's a great way to illustrate what I'm talking about here, is that each provider may be scored in one MVP. So if a provider is in the lower extremity joint repair, they cannot be in any other MVPs. But in an integrated practice, a provider may contribute data to many MVPs. And so as your MVPs share improvement activities, foundational layer, sometimes cost measures, you can standardize the workflows between your MVPs. So even though each provider is going to be scored only once per MVP, it is still possible to work together. And in the end, this is what it should look like. You should be able to devise and implement a self-fulfilling strategy. So you look at your improvement activities, for example, to engage beneficiaries in condition management and access to results. What that is going to do, it's going to reduce unnecessary admissions. So there's what we talked about in the foundational level and in the cost level, promoting interoperability scores, again, that foundational layer. You will see those improvement translates into lower cost and improved quality performance. Wash, rinse, and repeat. This is going to be the way that your strategy keeps chugging along and building on itself. And this is how it might look. When you have someone with data and clinical experience expertise, that allows you to look at proactive population health interventions. As I said, it's not just looking at who's got a high A1C. If you look into the lower right quadrant there, you can see different types of targeted interventions for patients with persistently poor controlled outcomes. So just because someone has a high A1C, you're not going to necessarily be taking the same action for each of those. Is it an issue with medication? Is it an issue where the patient needs to be connected with, let's say, a dietitian, a nutritionist, a behavioral health clinician? There can be any number of different things here, and each one is going to follow its own path. You can transform quality measure shortfalls into improvements. So this is one of those targeted interventions that I showed you on that previous slide. You can look at where you started and your performance as you're moving along. Are you getting better? Are you getting worse? Are you the same? And if we are the same, or especially if we're worse, what can we change? This works great for piloting certain interventions before rollout. Few physician champions are able to look at this first, figure out where their colleagues are going to be able to succeed and what is going to trip them up. And so when it comes time for a full rollout, it's much more smooth than an all of a sudden brand new program. So looking at the future, MVPs are definitely here to stay, but some of the details are murky. And here's what I mean. There's no defined time frame for mandatory MVP or subgroup reporting. It has been proposed as possibly in the 2025 range, but it's not been finalized, and that was proposed last year. New MVP candidates are proposed each year. So those proposed versions are published, public feedback is posted, and then those versions may or may not be in proposed rules. Based on feedback received, what was in the proposed rule could or could not be in the final rule. And that is rather challenging because final rules are generally published in November. And the specifications that go along with each of those measures that are in that MVP are published for your review on or before January 1st, meaning you will know the details of the measure possibly the day before you're actually supposed to begin using it. I hope you did not have New Year's plans. So the upshot obviously is that you're going to have very little lead time. So with knowing that, you need to create and establish a set of core principles that are going to help you succeed in any value-based care program. So whatever the measures are, whatever the details are in some of those measures, whatever program you're in, there are a few things that you're going to do that are going to be able to carry you through it. The first is to align your efforts to maximize results. If everybody is not moving in the same direction, it is challenging to make any forward progress. You need to educate providers and staff on standardized data collection and input techniques. Do not cede credit for quality care. Make sure that you're entering the information in the same type of location. And this applies for all measures, whether you're reporting electronic clinical quality measures, there's specific places that those pieces of information need to go. You have more leeway with clinical quality measures. You can find more on that in our last webinar here. But for each type of measure, whether it's ECQM, CQMs, or the soon-to-be coming digital quality measures, there are going to be ways that the information needs to be recorded for it to help you. You need to examine whether procedural episodic costs vary by either provider or site. Investigate the root causes of persistent poor control. So it's not enough just to know that you have a certain rate of diabetic patients who have high A1Cs. You need to know those patients with diabetes, what specifically is behind that. You need to understand your patient's social determinants of health needs. CMS published a white paper yesterday evaluating social determinants of health and whether or not some of its existing programs in the Innovation Center are appropriately addressing social determinants of health, because outcomes are so, research has been showing that outcomes are so closely tied to things like food insecurity, housing insecurity, living environment, etc. And finally, demonstrate that high single standard of care. You don't want to get so mired in the what and why of each individual program that you're participating in that you lose sight of the fact that if you do provide a single high standard of care, you'll be successful in any program. And just a couple of images here. This is what it might look like to help identify chronic condition variations by provider and site. Are we saying that the three up on the right, the top right corner, are worse clinicians? No, of course not. But there may be things to investigate, conversations that should be had. It could be just a question of the population, but you will not know until you see the data in front of you and are able to look at your referral patterns and understand whether or not they're based on hard data or the fact that one clinician went to school with another, plays golf with another, their kids are friends, something concrete. And this is the same type of view, but if we're looking at procedural costs, comparing them by provider and site, do we see a different percentage per clinician or site for notable observations? Notable observations are things that drive costs. They're not necessarily errors, but they're something that are going to be a cost driver in some of these procedural episodes. And that brings us to questions.
Okay, Wonderful. Well, gosh, there's a lot here. But Dave, I think you did a great job of explaining all this, even from basic levels. So don't be discouraged if your head is kind of spinning around about this. You know, you're not alone out there, but you've got folks like Dave who can be there for you to help answer the questions. Speaking of which, we did have some questions coming in, and if you have one, please go ahead and ask it now using your control module with the little question area on there, and we'll get to as many as we can. First question is this, in no particular order here, is how does CMS know that you should be scored according to, I'm sorry, how does CMS know that you should be scored according to MVP rules? Does that make sense to you?
Yeah, but okay, yeah, I got it.
Sorry, I've kind of butchered
If
that question.
there was a slide where I mentioned MVPs concurrently with traditional MIPS, or one versus the other, how do they know? So let's say you only submit 4 measures. How do they know that you are submitting the appropriate number of measures rather than the measures, rather than submitting only the 4 out of 6 for traditional MIPS? They know because there is a registration for MVP reporting. And so to report
Okay.
an MVP, there's a website that you go to, the Quality Payment Program, which is QPP, as in Quality Payment Program, .cms.gov, and you're able to register. If you are a security officer for your practice, you're able to sign people up to register to report an MVP. So when a third-party intermediary submits data on your behalf, there's an identifier that says that we are submitting data for these group of providers, and it should be scored as an MVP.
Okay, great. Next question is, what happens if I register for an MVP but realize that it's not feasible?
That is actually all right, and that's one of those sort of beneficial scoring rules right now. If you register, you are sort of put on the guest list, but you don't have to show up for the party. So if you do not register for an MVP, or excuse me, if you register for an MVP and you just choose to report for traditional MIPS, right now that's fine, you're not penalized. But if you do not register by the end of November and you try to submit one, it will be kicked out by the CMS submission engine.
Oh, wow. Okay, that's good to know. Next question is, none of the MVPs look good to me. What should I do?
That is not surprising. There are more of them than were anticipated, but obviously with specialties and subspecialties abound, there are going to be some people who are left out. Every year, more MVPs are proposed, and so this is something where you should talk to your representatives at various specialty societies and ensure that when an MVP is proposed, to look at what they are, and that's again on that qpp.cms.gov site. There's a comment period available, and so this is something that you have the ability to control in the future. Once again, a great reason for starting early to understand what's out there and what you will need to be out there in order to be successful. You don't want to realize come mandatory MVP time that there isn't anything that looks right for you.
Good counsel. Next question here is, do we see MVPs being developed around diagnosis/treatment bundles or individual specialties?
Both. Absolutely. I could expand on that plenty, but it is both. I would imagine, particularly as certain conditions, certain organizations want to see these things measured. You may see one, let's say, that is put forth by someone like the American Diabetes Association that is specifically diabetes related. But likewise, you may see something put forward by some of the specialty societies, specialty academies, and then finally, there are some people out there who are going to try to come up with their own that works for them specifically. They may not come from just one of the large organizations. This is something that's open to the public.
Wonderful, wonderful. Well, that is actually all the questions that have come in. So unless anyone has one in the next couple seconds. All right, well, let's go ahead and wrap this up for today. Dave, thank you so much. I really appreciate you explaining this to us. I know that I've learned a lot personally. As we close out, I'd like to encourage all of you to stop by vbcexhibithall.com and check out the Roji Health Intelligence virtual booth there. And what that is, it's kind of like a snapshot of what they're doing in the value-based care space. You can read up on them, learn a little bit more about their team, about what they're up to, see some different resources that they have. And of course, it's you can visit this. It's free. It doesn't cost anything. You don't even have to register. Just head over there and check it out. There'll be a link in the slides that I send you afterwards. And then finally, if you would like to get in touch with the team or with Dave or with Dan, who's in business development, please reach out to them directly. Their information is here on the screen, or feel free to reach out to me. I'm happy to facilitate an introduction for you, and they'll be able to handle any RFPs that you might have or any just general questions. And they're a great team. I've worked with them for a long time, so you definitely will be in good hands with them. So thank you so much again, everybody, for joining. You will receive a link here soon with an email here soon with a link to where you can rewatch the session or share it and also download the slides. So that'll be coming to you shortly. So thank you all. Have a wonderful afternoon, and we will see you next time. All right. Goodbye, everybody.